Hey everybody and welcome back. Today is going to be a bit of a, I don't want to say denser topic, but a topic that is more so targeting people in the healthcare field or trainees, nursing students, medical students, residents, docs, NPs, PAs, paramedics, what have you. But it is also a really important topic for the general public and anyone just interested in learning more, and that is anaphylaxis. So today we're going to talk about what anaphylaxis is, both from kind of a bird's eye view as well as get into a little bit of the pathophysiologic view, what's happening with the immune system to cause anaphylaxis. We'll talk about how common it is, how to diagnose it, what to expect in terms of signs and symptoms, history and physical, how to evaluate for it, including the specific diagnostic criteria, and then how to manage it, how to treat it, things to be aware of, things to know. And last, we'll end with a little World Health Organization kind of picture graphics on different parts of anaphylaxis, just to tie it all together in a more simpler way. So stick around. We're going to break for a 60-second introduction, but we will see you right after the intro. Hey everyone, and welcome to another video here at Whiteboard Doctor. Thanks for joining us today. Quick disclaimer before we move on. None of these videos are intended to be acted upon as medical advice. Please pause the video here and read the disclaimer in its entirety before moving on. Channel plug. Here at Whiteboard Doctor, our mission is to bring you interesting, relevant, and understandable medical education for all types of lifelong learners, trainees, and practitioners. If you want to follow along, we do have a lovely subscribe button in the bottom right-hand corner of all the videos. Don't forget to hit that like button. And lastly, if you'd like to support us outside of viewing our videos, we have several ways in which you can do that, linked in the video description and pinned comment. Stay well, keep learning, and all right, thanks for sticking around. So with no further ado, anaphylaxis. So anaphylaxis is defined in a number of different ways. And I don't want you to feel like the definition is the way to diagnose it, because there's very specific diagnostic criteria, but the definition, the kind of simple way to define it, is an acute systemic hypersensitivity reaction. So what does that mean? Acute means quick, right, in onset, so it happens quickly. Systemic means kind of whole body, so it is affecting the whole body. And hypersensitivity reaction is a type of reaction that we categorize, which is related to immune system dysregulation. So your immune system kind of goes wonky. And the immune system, or the part of the immune system in this case, is primarily mast cells. And we're going to get into what exactly mast cells are. But you get this quick whole body immune system deregulation. It is primarily IgE-mediated, and we're going to get into what that means as well. But IgE is a type of immune globulin or antibody, all right? And it is at the center of this mast cell degranulation. So when we talk about hypersensitivity reactions in immune system dysfunction, we're talking specifically about IgE-mediated mast cell dysfunction. All right. Of note, and we put this down here, we're not going to get into this portion too much, but there's a very similar type of reaction called an anaphylactoid reaction, right? Anaphylaxis versus anaphylactoid. An anaphylactoid is actually IgE independent, meaning it doesn't have the same mechanism that requires IgE as anaphylaxis. Now, in more recent days, some combine these terms, anaphylaxis and anaphylactoid, because the treatment, TX treatment, is similar. But for the strictest definitions, many would say anaphylaxis and anaphylactoid are different reactions, and we're going to focus specifically on anaphylaxis. And then one thing to really note is this actually can be life-threatening. It is very important that it is identified early and treated aggressively, because you can die from anaphylaxis, and in many cases it can be a preventable death. So this is kind of the word, definition as defined by words. Over here, I'm going to say this is somewhat of a picture graphic definition of what's happening. And we're going to get into this in more detail. But a mast cell is one of your immune cells. So they're cells floating around the body that are part of the immune response. And mast cells collect these IgE immunoglobulin receptors on their cell membrane, right? We said it's IgE mediated. So they collect these immunoglobulins on their membranes intentionally. And when those IgE immunoglobulins come in contact with what we call an antigen, which can be anything, right? Bee sting, poison, a certain food, a certain medication, anything that you have for some reason developed an immune sensitivity to, that mast cell might detect it through the IgE immune globulins, and then it does this massive, what we call degranulation, and that's what we wrote out here, degranulation. And what that degranulation is that mast cell just kicks out a bunch of kind of signaling mediators. The primary one that you hear about is histamine, but we're going to talk about a number of these degranulation mediators and what exactly they do. But that's the simplistic version, is your mast cells floating around with these IgE immunoglobulins detect an antigen that for some reason you've developed a sensitivity to, and the mast cells just dump out all these allergic mediators, with histamine being the primary mediator that then causes this big systemic hypersensitivity reaction, right? All right, how common is anaphylaxis? Well, the lifetime prevalence is about 1 to 3%, but many say anaphylaxis is underdiagnosed, and we're going to get into why that might be. But the most common prevalence stated is 1 to 3% lifetime prevalence. It equates, though, to as much as 1,500 deaths per year. And when we think about the people who can have anaphylaxis, this isn't affecting, elderly and comorbid people or elderly individuals with a lot of past medical history. This can be children, right? It could be neonates or very young people, although we'll cross that out. Probably not common neonates, but children, adolescents, young adults, and obviously adults and older individuals. But it can affect the full spectrum of ages. So when we think about 1,500 deaths per year, this is concerning because it is something that's often preventable and can affect young people. And looks like we read our own mind twice, more common in younger folks, often misdiagnosed. And there's some very specific reasons for why that might be. Reasons important to note, not just for people working in the medical field, but also people out in the world need to know how to identify the causes of anaphylaxis and the symptoms and signs of anaphylaxis so that they can treat it quickly. The pathophysiology is spelled out here, and then we're going to kind of draw it out again in picture format, but it's a type 1 hypersensitivity reaction. There's 4 types of hypersensitivity reactions. We're not going to get into each one. That's above the scope of this video. If you're interested in a video on that, let us know. We're happy to make it. Hypersensitivity. But type 1 hypersensitivity reactions are IgE immunoglobulin mediated. There's other types. Some are immune cell mediated, some are immune deposit mediated, etc., etc. But this is IgE, immunoglobulin E mediated. And an important thing to note is that it actually requires a re-exposure event, meaning the person had to be exposed to that antigen. Right? So here's the antigen. The antigen is this thing that you've become sensitive to. You had to be exposed to it one time already. And then after that initial exposure, when you are re-exposed to it, that's when you could develop an allergic reaction or anaphylaxis. And then it primarily involves mast cells and also basophils, both to immune cells, which we will get into more when we look at the mechanism here. This is the mechanism drawn out, and it looks simplistic, and that's because to some degree, it is not massively complex, at least in understanding how exactly it happens, although this exact details can be more complex. But you first have this initial exposure event. And this initial exposure is you are exposed to an antigen. For the sake of this understanding, let's just say it's a food. We'll just pick peanuts. So you're exposed to peanuts for the first time, and for some reason, your body has decided it's going to be sensitive and allergic to peanuts. The way that happens is your B cells are part of your immune system, your adaptive immune system. The B cells produce antibodies, also known as immunoglobulins. Your B cells identify these peanut proteins that are floating around in your body, and they say, wait, we don't recognize that peanut protein. Even though we're supposed to, we don't. So we are going to start an immune reaction to that peanut protein. And the way we're going to do that is we're going to grab onto that peanut protein, we're going to bring it into our cell, we're going to break it down into smaller proteins, and then we're going to produce immunoglobulin E, or antibodies, specific to that peanut protein. And what happens then is, as these antibodies, these IgE immunoglobulins that can identify that peanut protein, are floating around, your mast cells, another immune cell, grabs on to those antibodies, those immunoglobulins, and deposits them in their cell membrane facing outwards. But this takes time, and that's why the initial exposure, you actually don't have an allergic reaction, because this all takes time to happen. But then you have these mast cells that are floating around in your body for an indefinite period of time that are sensitive to this peanut protein, right? They have all these IgE immunoglobulin antibodies that are specific to the peanut protein in their cell membrane. And they're floating around just waiting to come across that peanut protein again, because for some reason your body has decided that the peanut protein is an invader. It's an invading protein. It's not just from food. It mistakes it for something else, and it forms this immune response to it. So then when you get peanut protein again, let's say you loved those peanuts so much the first time, you eat the peanuts again. Well, now your mast cells are locked and loaded. They already have all this IgE immunoglobulin antibody on their cell surface waiting to detect more peanut protein. And when they do, your mast cells do this massive degranulation event. There's literally all these physical granules of inflammatory mediators in the mast cell. And when it detects that protein, it says, hey, wait, this is a foreign protein. This is an invader. This isn't supposed to be here. I'm going to dump out all these inflammatory granules into the body to start this massive immune response, because I think I'm supposed to attack this peanut protein. Because during this initial exposure, my B cells decided that that peanut protein was not just a peanut, it was some kind of foreign invading protein that needs to be protected against. And now my mast cells are doing that. They're saying, wait, we see the peanut protein again. That's not supposed to be here. We're going to do this massive degranulation of all these inflammatory mediators into the body, because we think that's protecting the body, but it's a mistake. It's an error, because the peanut protein isn't doing anything harmful at all. In fact, it's just because you ate peanuts. And most people can tolerate peanuts, but those that are allergic, this is why. Their body has mistakenly identified that peanut protein as something the immune system should attack, and your mast cells do that with this massive degranulation event. And basophils are just another kind of immune cell which do the same thing. So what happens then? Well, what happens is your mast cells secrete all these inflammatory mediators, one of which, and the main one we think about, is histamine. And what histamine does is it increases your vascular permeability. What does that mean? Well, your vascular permeability, you have blood vessels, right? Your blood vessels are made up of individual cells called endothelial cells. And these endothelial cells are stuck close together so that no blood or fluid in any real way can leak out of the blood vessels. Well, vascular permeability essentially means that these blood vessels get leaky. All right, there's little kind of leaks in them, so that fluid then can leak out of the blood vessel into the extravascular space, or your soft tissues, and cause swelling. Does that sound familiar with an allergic reaction? So this increase in vascular permeability is because your blood vessels become leaky, and fluid from inside the blood vessel starts to leak out into the extravascular space, your soft tissue. So because of increased vascular permeability, you get swelling. That might be swelling of the lips, that might be swelling of the throat, that might be swelling of the intestines, that might be swelling of the skin, but you start to get swelling. You also get vasodilation, which means that these blood vessels start to dilate. They start to get engorged and swollen. And then histamine also causes itching. If anyone's had an allergic reaction, many people know it can be very itchy. Another thing it releases is mast cells degranulate is a molecule called tryptase. The significance of this we'll get into later, but you can actually send it as a piece of blood work to support anaphylaxis as a diagnosis. But again, we'll talk about it a little more in a bit. And then a number of the degranulation mediators are converted into leukotrienes and prostaglandins. And the significance of these two things is they cause bronchoconstriction. What bronchoconstriction is if we draw, let's see, we'll try to draw, that's one lung, this is the second lung, this is the trachea or windpipe, which breaks off into bronchi, is what they're called. And then those bronchi break off into a bunch of small bronchioles, and that's how oxygen gets into the lungs. So bronchoconstriction is when these bronchi constrict, they get smaller. And one could imagine if you're trying to pump air through this size bronchiole, that oxygen will flow smoothly, right? Because it's nice and big. But if you're trying to pump the same amount of air through a bronchoconstricted or a smaller bronchi, because there's bronchoconstriction from the leukotrienes and prostaglandins, that air is going to have a harder time traveling through because it's so thin. And that's why you can get things like wheezing and hypoxia is low oxygen levels and increased work of breathing. And then the leukotrienes and prostaglandins can also, just like the histamine, increase vascular permeability, meaning your blood vessels get leaky and cause soft tissue swelling, and then vasodilation, prostaglandins can. So these molecules that the mast cell is degranulating into your systemic circulation, into your blood vessels that then circulates around your body, you can understand how some of the allergic reaction symptoms result from these molecules directly. So that transitions into then the next section, which is history or physical. So what do you expect to see, both if you're trying to diagnose and treat anaphylaxis, as well as if you're the one who develops anaphylaxis? What should you be looking for? Well, the first things to note is it most often rapidly evolves, many times within an hour. So you have to be very cognizant in terms of diagnosing this. This isn't something that you can think about for an hour or two. You have to get on this quickly. All right, and we're going to get into this after we talk about the right section, this biphasic reaction. But it evolves rapidly, and the things that evolve rapidly are often swelling. You can see swelling of the lips, face, and eyes, right? We talked about up here the vascular permeability or the leaky blood vessels that cause the soft tissue swelling. You can get hives or welts, often called urticaria in the medical setting. You can get tingling in the mouth, which is a manifestation of some of that kind of itchiness and soft tissue swelling. And then you can also get abdominal pain and vomiting, specifically with insect stings, but really with anything you can. So you can get GI symptoms. It's critical in these patients to look in the mouth and look underneath the tongue for any sign at all of swelling. And in addition to that, anaphylaxis can often cause difficulty or noisy breathing, again, swelling of the tongue, swelling or tightness of the throat that many patients describe as a lump in the throat, hoarse voice, wheezing or cough, dizziness or collapse. They get pale, abdominal pain, and vomiting. So if we think about a lot of these symptoms, they kind of fit into these four organ system categories. So skin, swelling, lips, tongue, mouth, urticaria or hives or welts on the skin. Respiratory, wheezing, difficulty breathing, increased respiratory rate, cough. GI, abdominal pain, vomiting, diarrhea. Cardiovascular, dizziness, low blood pressure, collapse. So they track to these four organ systems as the organ systems that are most often involved. So make sure you look at the entirety of the skin. Listen to the upper airways, so listen to the throat for any signs of stridor, which is kind of noisy breathing in the upper airways, as well as lower airways for any signs of wheezing, which can be from the bronchoconstriction. Ask them about GI symptoms. Do they have abdominal pain, vomiting, diarrhea? And then ask them about lightheadedness, passing out or syncope, dizziness, etc., etc. Check their blood pressure, all those types of things. So we'll get into some of that when we talk about evaluation and management. So that's the history and physical. If we're going by formal evaluations, though, how do you formally diagnose anaphylaxis? Well, the diagnosis is a clinical diagnosis. There is no piece of blood work, no imaging test that will diagnose this. This is based on your clinical history and physical. And there's not many things totally like that anymore, given how advanced a lot of our testing is. So there's a beauty to it, but also a challenge to it, because there's no piece of blood work or imaging that you can get back in a decent amount of time to clinch this diagnosis. It is based off your history and physical exam. So there's no kind of acute lab or imaging to do to diagnose it. So then how do we clinically diagnose it? Well, we're going to go through two kind of charts. They're similar. One is by the World Health Organization from the World Allergy Organization Anaphylaxis Guidance of 2020. We'll obviously link it in the video description. This is their table. And they go on to say anaphylaxis is highly likely when any one of the following two criteria are fulfilled. So there's criteria 1 and criteria 2. And criteria 1 says acute onset of illness, minutes to several hours, right? We talked about up here how it's rapidly evolving. It happens quickly, with the simultaneous involvement of the skin or mucosal tissues or both. So this is things that we've talked about. Swelling of the lips, face, eyes, hives or welts, tingling in the mouth. So any involvement of the skin, and then at least one of the following. So it's kind of skin involvement plus, and then plus one of the following. And that can be either respiratory compromise, shortness of breath or dyspnea, wheezing when you listen to the lungs, stridor when you listen to the upper airways, hypoxemia or low oxygen levels, or reduced BP or associated symptoms of low blood pressure. So did they pass out or syncopize? Were they incontinent of urine? Do they have kidney dysfunction or heart dysfunction or liver dysfunction, or they're confused and not mentating? Or severe gastrointestinal symptoms, abdominal pain, vomiting. And this, again, they kind of qualify it. You see this more often after exposure to non-food allergens. But it's skin plus either GI or cardiovascular or respiratory. And that will get you a diagnosis of anaphylaxis, which is consistent with what we saw up here, the most likely kind of signs and symptoms, right? They were skin, gastrointestinal, respiratory, and cardiovascular. So remember, the diagnosis said it can either be 1, which is skin plus any one of these three things, or it could be 2. And 2 is that you had the acute onset of hypotension, which is low blood pressure, or bronchospasm, which is that bronchoconstriction and wheezing in the lungs, or laryngeal involvement, which is throat involvement, after exposure to a known or highly probable allergen within minutes to several hours, even if you don't have any skin involvement. So this is for patients who have known allergies especially, right? You know you have a seafood allergy and you just couldn't resist. You decided that you're going to eat the lobster at dinner. And then you come in and you have either a low blood pressure or bronchospasms and wheezing or swelling in the mouth. That would fit this criteria too for the diagnosis of anaphylaxis, even if you didn't have skin involvement. So you either have skin plus another organ system involved, or you have a known or highly probable allergen with any one of what I'd call kind of severe, apologies for that, severe organ system involvement, being low blood pressure or bronchospasms in the lungs or swelling in the throat. And another version of this was spelled out in this article, which I'll link in the video description. Here is the citation for it. But they say something very similar for their definitions. So clinical criteria for anaphylaxis, one of the following, with onset and set aside minutes or hours. So I put this on here just so you could see what was consistent and what might be a little different, right? But minutes to hours is consistent across both and consistent with what we've been talking about. These are acute, quick, fast reactions. And they say if you have an unknown exposure to an antigen, yet you rapidly develop urticaria, hives or welts, or other skin or mucosal symptoms associated with any of the following. And yes, you guessed it, any of the following are going to be respiratory symptoms, cardiovascular symptoms, including anything like end organ dysfunction. So the difference here is they do not have any GI symptoms that they mention in their diagnostic criteria for this first one, the unknown exposure one. So the unknown exposure one here is any skin or mucosal involvement plus either respiratory or cardiovascular. And in cardiovascular, I tend to bridge these two together, 2 and 3, because I think they're similar. If you have a low blood pressure, it's a cardiovascular involvement. Or if you have any end organ dysfunction, right? It means you're not perfusing your organs, so you pass out, or you're incontinent of urine, or you have low tone in your muscles, right? These are things we don't typically think of with anaphylaxis, right? If someone comes in and they have urticaria and they were incontinent, I don't immediately think of anaphylaxis, but you should. And that's why they have this in the definition, the diagnostic criteria. So then these authors similarly have a second set of criteria, and this is likely exposure to an antigen, which is an allergic mediator, right? So likely exposure versus unknown exposure. And in their likely exposure, they say likely exposure and then any two of the following. And here is where they have skin involvement, respiratory symptoms, cardiovascular symptoms, or gastrointestinal symptoms. So their definition essentially says GI symptoms only if it's exposure to a known antigen. And I'm not at all saying one, either the World Health Organization or these authors' definitions are better, but I think it's important to note how subtle anaphylaxis can sometimes be, or how kind of misdirecting the symptoms can be. But if you have a known exposure and you have any two of the following, skin, respiratory, cardiovascular, GI symptoms, that's pretty diagnostic because that's also in the World Health Organization's definitions, right? If you have an unknown exposure, there's some variability in definitions, but if you have respiratory, if you have skin plus or minus respiratory or cardiovascular involvement, that is anaphylaxis. The grayer area, the area where there's not total consensus, is if you have an unknown exposure and then you have skin plus GI dysfunction. And that's more kind of in the gray, right? The World Health Organization would suggest that if you have skin, right, and GI dysfunction, if it's severe, then you should call it anaphylaxis. Whereas these authors would suggest if it's an unknown exposure that GI dysfunction does not necessarily come into play unless there's end organ dysfunction with it. But as we'll talk about, being aggressive in your early treatment of anaphylaxis is critical. So low threshold to diagnosis as anaphylaxis. Hopefully that makes sense. I thought providing two separate kind of definitions of diagnostic criteria might be helpful in terms of kind of seeing the overlap and the difference. They do put a caveat in their definitions. If you had a known exposure and you're hypotensive, call it anaphylaxis. And these authors do provide the caveat. It is not required to meet these criteria to treat. This is simply meant to serve as a guide, right, to diagnosis, which is in concurrence with what we talked about. You kind of want to have a low threshold. You want to have this in your brain and probably over-treat rather than under-treat it. So this transitions into, again, there's no real diagnostic labs or imaging that diagnose anaphylaxis, but tryptase is a lab to think about, especially if you're working in the emergency department, because tryptase is a mediator that's secreted by mast cells. We'll scroll up and show you as a reminder, right? Mast cells degranulate with the re-exposure, and tryptase is something that they degranulate and secrete. And it peaks, their tryptase levels peak in 1 to 2 hours after exposure. And what this becomes helpful is actually in the outpatient setting. So let's say a patient comes into the emergency department, they've got skin involvement and GI involvement, no known exposure, and you're like, gosh, this could be anaphylaxis, but we're kind of in the gray. I'm going to treat it like anaphylaxis because I'd rather over-treat than under-treat, but I'm going to send a tryptase level. And the reason I'm going to do this is not because I, in the emergency department, am interested in it, but because the allergist in the outpatient setting might be interested in it. Because if the tryptase is high when I sent it, that would suggest that it was in fact anaphylaxis. Whereas the tryptase, if it's low and it was sent at that 1 to 2 hour peak, although not a perfect test, might support that maybe this wasn't anaphylaxis. Does that make sense? So the tryptase can be a strategic lab to send in the acute setting, especially in the emergency department or within 1 to 2 hours of that exposure, but not because it's useful for the emergency medicine physician or physician assistant or nurse practitioner or what have you, but because the outpatient allergist can use that tryptase to further guide whether it was in fact anaphylaxis. All right, that gets into management, the good stuff. So the emergency medicine, physician in me always starts airway, breathing, and circulation. So anaphylaxis in its worst form and in some of the scarier airways I've come across can cause a lot of oral and pharyngeal edema or swelling. So when you're evaluating their airway, look around their mouth, so look at their lips, look lingually at their tongue, look in the back of their throat at their pharynx, and also look under their tongue. Sometimes you can see this isolated sublingual edema. And then listen to their throat to make sure they don't have stridor. If there are these things, you have to have a low threshold to intubate them, put in a breathing tube, because that swelling could get worse. And if you wait too long, they could become an extremely difficult airway, right? Because they might swell so much that their airway closes off and you can't pass that endotracheal tube. Next is breathing, right? You're going to look for any increased work of breathing, any wheezing, tachypnea or high respiratory rate, hypoxia or low oxygen levels, and supplement them with oxygen if they have low oxygen levels. And you can try giving them a bronchodilator like nebulized albuterol, which is a short-acting beta agonist, to see if that improves their wheezing. But we're going to get into this. This is adjunct treatment. And then circulation. We talked about how they can have, patients with anaphylaxis can have low blood pressure, hypotensive. They might be tachycardic with high heart rate. IV fluids and vasopressors are also adjunct treatment. But the big thing, the far and away thing you want to do for these patients is epinephrine, 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 epinephrine. All right? Epinephrine is the treatment for anaphylaxis. All this other stuff, bronchodilators, fluids, vasopressors, those are all adjunct therapies. But epinephrine is what is really going to save that patient's life. And EpiPens are what some patients who have allergies have at home. And that's what an EpiPen has in it, is epinephrine. So you want to give epinephrine if they fit these definitions for anaphylaxis, or if you're worried about anaphylaxis in the patients, give them the epinephrine. All right? Don't wait, right? This is fast in onset. Things happen quickly. Intramuscular epinephrine is actually the preferred modality, even in the healthcare setting. It's been shown to be better than intravenous and sub-Q. The thigh is the preferred place to give the intramuscular epinephrine. Deltoid you can also do, but thigh is preferred. And you can repeat this every 5 to 15 minutes. If you're at home and you gave yourself your EpiPen, write down the time you gave it. That can be really helpful to us who then see you in the emergency department to know when you got your EpiPen. Most people respond to a dose of intramuscular epinephrine. If you didn't respond to the first one, the majority of people then respond to the second dose, excuse us. Some people are resistant and end up on things like epinephrine infusions, which is something we're not going to talk about a lot in this video, but intramuscular epinephrine into the thigh in a timely manner is the gold standard therapy. There are adjuncts though, and I do want to say the adjuncts that we're going to talk about, there's minimal kind of literature-based studies and evidence to support their use, but we use them, and there's some rationale for why we use them. And the big adjuncts are up here, bronchodilators, which we talked about. If there's wheezing, you can trial a bronchodilator, something like albuterol, all right, to see if that improves the wheezing. And then there's steroids. Steroids theoretically blunt this biphasic potential. So biphasic, what is that? I'm going to scroll back up because we kind of brushed over it up above. And what the biphasic response is it's this entity that some have seen with anaphylaxis where you actually get better And then in some very broad range of time, anywhere from a couple hours to I think I've seen even a couple days, you get recurrence of your symptoms. And some have estimated as many as 20% have a biphasic response. Anecdotally, that's not necessarily what I've seen in my practice, but that's what many people quote. And the peak time, the most common time to see the biphasic response is 8 to 12 hours after the first anaphylaxis response. So you essentially, they call it biphasic because you have this bad anaphylactic response, your symptoms are bad, 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 they get better, symptoms are good, and then all of a sudden your symptoms come back. Now usually the symptoms in the biphasic response aren't as severe, but they can be. And that is what the steroids are theoretically for, to try to blunt that biphasic response. So you get a dose of steroids, you get prescribed steroids, many people do about 3 to 5 days of steroids, and that steroid is an immunosuppressor, right? It suppresses your immune system and theoretically might make you less likely to have this biphasic response. Although when they do studies, it does not necessarily seem to be all that helpful. But we do it. I do it. I think it is probably the mainstream, I don't want to say standard of care, but the mainstream adjunct medication that's given. Antihistamines are another one, both H1 blockers, which is histamine receptor 1, and that's like diphenhydramine or Benadryl. And then some also give H2 blockers, which are things like ranitidine. H1 blockers are the more common histamine blocker given in allergic reactions and anaphylaxis. And H1 blockers do help with itching. Now, whether they help with anaphylaxis is somewhat of a different question, but they do help with the itching component of it. H2 blockers are even less well supported. Now, there is some kind of benchtop data to suggest that H2 blockers can have some crossover effect and help with some of that initial histamine response. Because remember, if we scroll up and again go back to what the mast cell is degranulating, histamine is a big part of that. So conceptually, it makes sense to block histamine receptors as a way to maybe blunt the anaphylactic response, but again, minimal evidence. Practice patterns would support giving steroids and H1 blockers like diphenhydramine, but whether they really help is a different question, with the exception being diphenhydramine does seem to help with itching. Do remember they take time to work. These are not replacements for epinephrine, right? Epinephrine, again, is the treatment for anaphylaxis above and away. All these are adjunct medications that can be considered. And again, many of them are prescribed for 3 to 5 days, even after the anaphylaxis resolves. If you get epinephrine, if you give epinephrine, many people monitor those patients in the emergency department or in the hospital for 4 to 6 hours, and always, always, always send that patient home with EpiPens. All right? They had what seems to be an anaphylactic reaction. They should go home with an EpiPen. They should be taught how to use the EpiPen and the symptoms that would support using that EpiPen. They also, if it was a known allergy, make sure that allergy is on their allergy list, and make sure they have follow-up with an allergist, right? If you sent that tryptase level, that allergist can follow it up. All right, that is the bulk of the presentation. We just have some graphics from the World Health Organization to kind of tie some of this together, but it's more simplistic graphics to further give us a visual on some of these things. So the World Health Organization, again, we'll link it in the video description, has drawn, remember, the diagnostic criteria. So this is representing skin involvement. It can be hives or urticaria. It could be mucosal involvement, swelling in the mouth, and at least one of the following, oh, we didn't mean to cross that out, one of the following, which can be respiratory symptoms, right? Wheezing, stridor, low oxygen levels. It can be cardiovascular symptoms. So things like reduced blood pressure or associated symptoms of end organ dysfunction, meaning confusion, decreased kidney function, et cetera, passing out, syncope, incontinence, or severe gastrointestinal dysfunction. All right, so we have the GI, the respiratory, and, this is actually the respiratory up here. This is the cardiovascular down here, cardiovascular CV. And then their secondary definition, if we remember, right, this was 1. Their secondary definition, or 2, was the acute onset of hypotension, low blood pressure, bronchospasms or wheezing in the lungs, or laryngeal involvement, swelling of the throat, after a known exposure. And that's what they spell out here, right? Laryngeal involvement, which is swelling in the throat, bronchospasm, which is wheezing in the lung. You can see here they have a throat that's all red. Here they drew out the lungs. And also hypotension or blood pressure less than 90 systolic. All right. And this is some known allergens or more common allergens that the World Health Organization laid out, which I just wanted to briefly cover. And many times you won't be able to identify the trigger, but sometimes you can. And common ones are foods. Foods that are common are things like peanuts, fish, soybeans, eggs, tree nuts, fruits, sesame, shellfish, milk. Medications are common as well. Beta-lactam antibiotics are a class that can have allergies, things like penicillins. NSAIDs, which are things like ibuprofen, different biologic agents. Some people can be allergic to contrast, which is what you get for things like contrast CT scans. Different occupational allergens. I don't know why they put seminal fluid here, but apparently seminal fluid. Different environmental allergens, venoms, like bee stings or spider bites, natural rubber or latex. These are some of the common allergens that can cause anaphylaxis, although, really almost anything can do it. So that's all we have for you today. Hopefully that was helpful, enlightening, maybe even interesting, educational, what have you. Let us know what thoughts, comments, questions you have down below. Subscribe, hit the bell button if you want to follow along. We'd love to have you. And in any case, stay well, keep learning, and we will see you all next time.